Okay. Welcome back. So, thank you for all the attendees that are still here. I think since all the speakers for the next session, which is actually the last session of the day, is already here, I think we can start earlier so we can have plenty time, plenty space for discussions. And for the next session, as already Dr. Susil already mentioned, this is one of actually the most important things. But sometimes I think we as doctors or healthcare professionals often forgot. It's about patient safety, especially during this pandemic. It is actually much become a highlight in our daily practice. We have two prominent speakers from one is Dr. Jannicke Mellin-Olsen from Norway. She is the past president of WFSA. And we have Dr. Meena Cherian from Switzerland. Dr. Meena worked with the WHO and she has been published papers in the field of patient safety. And also for the discussion, also important person, Dr. Bambang Tutuko. He is the head of the Indonesian National Committee of Patient Safety. So I think we are very lucky today because we have three faculties in the field of patient safety. So our deepest gratitude for all three of you for giving time and effort to be here virtually with us. Hopefully, who knows, next year we can have a real face-to-face meeting. So without further ado, I would like to invite Dr. Bambang Tutuko as the chairperson. Please, Dr. Bambang.
Okay, thank you, Krisa, for your nice introduction for us. And thank you also for the Indo-Anesthesia, especially Susilo and Eddie, for giving though it's the last session, but it's the very important sessions. And we are lucky to have the very important sessions, the patient safety sessions. This afternoon, we have the privilege of having two important and prominent speakers in anesthesia and also in the world. Yes. Good afternoon, dear colleagues, participants from around the world and also from Indonesia. Dr. Jannicke Mellin-Olsen is our president 2018 and 2020, and she represents us in the World Health Assembly for the anesthesia service in the world. And Dr. Meena is the former WHO Emergency and Essential Surgical Care, who is raising the issue and for the service with the global surgery 2030. We know that she's raising the issue that anesthesia, surgery and anesthesia is not an individual privilege. It's a universal health coverage privilege. It's the privilege of all people in the world. And now for the first speaker, please, Dr. Jannicke Olsen. The topics will be patient view and patient safety. Your time is 30 minutes, but it's up to you. We have plenty of time. Please, okay. Dr. Jannicke, time is yours.
Thank you. That's good. I have much on my what I want to talk to you about. But first of all, thank you so much for inviting me. Thank you so much for preparing this special event. But for me, I would have been happy to listen to more music than more to myself, I must say, because this is
I do also.
So fantastic what we have. This certainly grooving music, which I start in the morning. For me, it's the morning. But okay, thank you very much. I'm going to speak to you about one very important topic, which we tend to sometimes not look so much into, and that's how the patients, what they are expecting from patient safety and what are patient safety views from their perspective. And here you can see all the hats which I'm having relevant to patient safety. Nothing involving money. I'm working in Bærum Hospital outside of Oslo, and otherwise I have had or having all these things. So just wanted to tell you those. And my talk is based upon a chapter I wrote in the Anesthesia journal, because it was 10 years last summer since the launch of the Helsinki Declaration on Patient Safety in Anesthesiology. And there we describe all stakeholders. And one of them, which we said, is that patients have an important role to play in their safe care, which they should be educated upon and given opportunities to provide feedback so that we can further improve the process for others. And we see now that the role of the patient in at least my part of the world, and I know elsewhere too, it's changing a little bit, because we used to have this very paternalistic role as doctors, that we were talking down to the patients, we were telling them what to do, and they really did not have much to say, and the hierarchy was very steep. So gone are the days where we are saints and angels. And also for the way we prepare our care. This Norwegian author once said that a sick man knows much of which a health person has no clue. And I think that's very important to remember, that the patients are the professionals concerning themselves. I mean, they know who they are, they know their care, their concerns, and so on. And we sometimes think we know, but we do not know. And some of us have been patients ourselves, and then we have seen our own roles compared to the doctor's role. And then as anesthesiologists, we are safeguarding the best interests of our patients whenever they are at their most vulnerable. Imagine what a patient has to do when he gives or surrenders himself into our care. Let go of all control. We have to take over all his control. He just has to trust that we are acting in his own best interests, and that's what we want to do. So that's in anesthesia, it's in intensive care when they are the sickest of the sickest, in pain treatment, and also in critical emergency medicine. And that's something very important for us as anesthesiologists. And there are some barriers. So why are we not involving them, or why are they not becoming as involved as they could be? Well, illness severity is obviously one thing. Our ICU patients who are unconscious, they cannot express to us what their perspective is. And also there are some cognitive characteristics. Not everybody is as able to convey their thoughts, their fears, or whatever. And of course also language barriers is one thing. And I don't know how it is in your country, but here we have sometimes when the patients don't speak our language, they have relatives interpreting for them, and that interacts with our communication because the relatives are not objective in that sense. And then, of course, if we are not communicating well, and I'm going to talk a little bit more in depth on that. And then, of course, we have organizational factors, including safety culture, and I'm coming back to that as well a little bit later. Here, I was supposed to play a video, but I think I don't want to do that because I have so much to say. But it's an example of very bad communication when the doctor is not looking at the patient all the time, interrupting, not listening to what his questions are, and so on. So you think, oh my dear, this is just awful. And it's very clear when we look at some of those demonstrative videos. But then to help us, there are some frameworks which we can use in order to do the communication more effective. And in my hospital, everybody all the employees have to go through this course, which is called 4 Good Habits. The concept was developed by Kaiser Permanente in the USA. And not all of this is equally relevant to anesthesia, but we used it in the pre-anesthetic clinic. I'm sure many of you have pre-anesthetic clinics too, where you talk to the patients in an office setting a couple of days before doing the anesthesia, so that you can find out if there are things you have to check and control further before you put them into elective anesthesia. But even if you don't have that, the principles are good to remember. And here are the 4 good habits. I'm going into them more in detail, all of them. And the limitations to the communication thing is that, of course, you cannot solve all the problems that you have. If you are not competent on a general level, it can't help you if you are a good communicator, because you have to know what you are talking about. And of course, this course is not aimed at any particular specialty. All specialties, nurses and doctors do go through it in my hospital. And we have the cultural things, which we also have to address now that we are giving these talks, because we live in different settings. Language problems I mentioned, but it's a start, a basic course which helps you moving on. And the first good habit is that you should invest in the beginning. And that's very important, because first impression when you meet another person is it's setting the tone for the rest of how you can communicate. So when you go and meet him and you can say just a few words, oh, I'm happy to see you here, good weather, I'm sorry the wait was long, or something, just to open up and to start the talk. And you can see here, this is from my hospital, what they made a new barrier to communication. So here is the person accepting the patient, and there is the patient. So I went to the engineers in the hospital and had to say they have to change these things, because that's not a good investment in the beginning of a consultation. And then obtain good contact with them, and just easy, introduce yourself to everybody and make eye contact with them. Say, I'm sorry you had to wait so long, if that was the case. And as I mentioned, social comment, ask a non-medical question to put patient at ease. And if you should never meet a patient without having read his chart beforehand, and just say, well, I know that you have those heart problems, and so then the patient becomes more confident in you. And also, as I said, cultural background and eye contact and body language. Be open and not close like this. Then to get the patient's concern, and that again is interesting that we are not so good at that, because we are in general very impatient. So we have a tendency, we ask a question and then we just interrupt. But we could say, for instance, what would you like help with today? And then we interrupt at an average of 11 seconds, but on the median, it takes 6 seconds for the patient to tell what it's all about. And open questions. I understand you are here because you are going to have a surgery for your bowel. Could you tell me more about that? And then when you have an interpreter, don't look at the interpreter, but look at the patient. So she or he understands that he's the most important, not the interpreter. Sometimes you have a tendency to forget that the patient is in the room and just talk to the patient, to the interpreter who is on your side. Eye contact and smile so that they feel that you are listening to them. And then if you repeat the concerns the patient has to check that you have understood the concern correctly. For instance, I'm afraid that the patient says, I'm afraid for the general anesthetic. And then go into, so you are afraid of the general anesthetic. Why? What is it about it that frightens you the most? And then also set expectations. in my experience, the patients often want me to talk about also sorts of surgical problems, how long they have to stay in the hospital, when they will be able to walk on their foot again, and so on. But say that we will do that later. This is not for me, so that we have the same expectations for what's going to happen in the consultation. And if the patient, this is maybe not so much for us, but for others, the patients have 3,000 problems, then we start with the most important, and then either go on to the next or say we make another appointment. But that's so much, not so much for us. Elicit the patient's perspective is another area. And that's, I once went to a talk in Germany at the German Society, which is one of the best talks I've ever heard. It was about nociception. And this colleague of ours had made a video about the patient being rolled into the theater, and all he could see was the ceiling. And you saw all those lamps coming over him like that. And just a simple thing to put up the head of the bed and move on would make it so much easier. I feel the patient much more in control. And the same is that when we are doing, when we are talking to patients who are on a stretcher or in the bed, and we look at him like this from above, of course that makes it very unequal. So that was something which actually was my suggestion that has now been all over the country, that when we go rounds, we carry this small stool with us. And then we can sit down and have eye contact with the patient in the same level. And there was one surgeon in the post-operative care unit, and the nurse came with this stool, and he said to the patient that, this nurse is coming with a chair, she's so pushy and so on. And then the patient said, well, yes, I think that's a very good idea. I feel very weak here when I'm lying in my bed and so on. And so the surgeon had to sit down and look the patient directly into the eye, which was a good thing at that time. So also the patients, we don't know what the patient really thinks, so we can ask questions. So what do you think is the cause of your problem? And what is your biggest concern? And then what has he done to treat her own illness? And also what other help he has got or support in the community? Are there others, some of your loved ones had any ideas about what this can be and so on? Could also be something that you can put in. But just because we are not in the patient's head, so we think we understand what the patient is concerned about, but we don't always do that. Of course, check the expectations. How do you hope I can help you today? And what are your thoughts and so on? It's the same things I'm talking about all the time. And sometimes the patients have very different expectations or thoughts on what might cause the problems and what's worrying him the most, and we can guess. And it's helpful for us to get to know that. And also the impact on life of patients and what the problems are, as you can see. Maybe, again, not so much for us, but this is the general setup of this program. Demonstrate empathy is a very important thing, and I use that a lot when, particularly with relatives in the ICU. And we can then see, well, I see that you are concerned, I see you are worried, and never say that I know how you are, how it feels for you, because you do not know how it feels for another person. Only the person can know that, but you can say that I see that you look worried. Then you are not telling the patient what he feels, but you are telling your own observations. Very important thing. And I know that many of my colleagues are worried about showing emotions, for instance, in very sad situation in ICU. This is partly a cultural thing, of course, but here I have never seen any family thinking that we are not professional if we show that we are touched in a very sad situation. Even if we cry a tear, we of course not lose control, but to show that we are emotionally affected by the sad situation that is happening in the room. But of course, when we are not there to put our emotions on the relatives, but we are there to see them. We have received your message, and we have accept that and support you. Sometimes also reflect upon the message and expand it. And again, very much when you are with a seriously sick patient or with relatives in the ICU. You are there with them. You use eye contact, of course, body language, be open, not closed, face expression, voice, and so on, and active expression of attention. Those things mean so much more than we normally think about. So as I said, we cannot say, I know how you feel, but we can say this cannot be easy for you. And you say you are afraid. This affects you, and also legitimation. I want to help you with. Let's see if we can together be so and say, well, I'm impressed that you are doing this and that. These are things that help you support the patient. Be open. It's allowed to talk about emotions, and we can listen to verbal and non-verbal hints. And that's a good thing about being an anesthesiologist, I think, because often it's not our main responsibility to take care of all these things, which means that we can be more at our leisure. We can take those hints, but it might not be it might be the surgeon's main problem, but we can support everything. So they have some hints, and I'm really curious about the outcome, which shows insecurity. Or say, I suppose I'm okay. And then you can opt to say, yes, of course, or yes, I hear, but, or something. And my batteries are empty. You can listen or let it go. But I mean, they are putting out some test balls, or what should I say for us, some baits which we can bite or not. And of course, if a patient just says that en passant that my father died of stomach cancer, and the patient itself has a cancer, that's a hint you should follow up on. Then you can say that the patient can say two things at the same time. And let's give this example. I have pain and neck in the shoulders, which is a symptom. That's almost unbearable. That hints a concern. Then the health worker can give several answers, either just ignore them or follow up and going deeper into the problem. And here is one example of different pathways of that. Let's say the patient has been diagnosed with diabetes. The doctor informs that he's going to prescribe metformin. And then the patient is quiet, look at the floor. What does the doctor do? Well, he can say, here's the prescription, then I think we are done. Or he can say, oh, how you get quiet? What bothers you? Patient, I got too much to think about now, a hint. Yes, you will be fine, I understand. Or think about what you have in mind. Yeah, my husband also got diabetes and took these pills a year ago. Then he got really sick. Yeah, there is no connection there. This is a well-known medicine with very few side effects. Or, oh, I didn't know that. You think it was the tablets that made him sick. You can see the very different courses of what's going on here. And then we have to transmit bad news. That's quiet place, sufficient time, check out the patient or relative's own understanding, what you know about this disease, and so on, because that will help you to let you know what you should say. And also, when you have bad news, this could be for a medical condition, or if we are in ICU and we see that we cannot help the patient anymore, then just say, I have bad news, or things do not look so good. Then the patient has time to embrace himself and expect that there will be bad news. Honest and direct, and no wrapping up of the bad news. And then ensure that the patient has time and opportunity to transmit reactions and emotions. Be empathic, of course, and ensure follow-up. This is not the last time we are going to talk about it. I'm here for you. The last, fourth habit is invest in the end. And yeah, well, the picture there is from the World Championship in cross-country relay from yesterday, where our team won the World Championship. So that's why I took this for investing in the end, when he has been spurting to get there. But okay, that was a sidestep. Deliver the information, whether it's diagnostic or therapeutic. So you just sum up everything and provide education. And then you should involve the patient when you make the decisions, because sometimes there are several, or almost always, there are several options out and complete the visit. I will tell you more about that, and it's the longest, and it must start early. So when you deliver the information, you inform on what you know based on the patient's own understanding, and make sure you prioritize. No medical language, as we know, and again, provide time and check that the patient has understood. Ask him to repeat if necessary. So what did we agree upon? Teach him reasons, side effects, and again, check understanding. And then if there are lifestyle changes, of course, you must, again, the understanding what should be done, and look at the opportunities, not the limitations. You will feel so much better if you follow my advice. And promote mastering. Written information so that the patient can go back and check, and refer to other sources. This is also relevant in our pre-anesthetic clinic when we talk about written information so the patient can check himself when he goes home before he's starting to fast. Involve the patients in the decisions so that she or he will take some responsibility for him or herself, and limitations for what is realistic. Round up and check out. Then you have more questions. Nice to meet you, and goodbye for now. So then you have made a good communicating visit or a pre-anesthetic clinic. And there are so many rewards for that, because you can see the list here. The patient feels better, reduced need for new consultation, and both staff and the patients would feel that this was good. We had a good talk now, constructive. So I talked about those 4 good habits, but then I'm going to talk more. I see it's towards the end, but I'm going, as you said, we started earlier, so I'm going to go some minutes over time, because these last factors are also important. It's for safety culture. That is in the best interest of the patient. But this is also said from the top. So if you work in a system that prioritizes that you can have so many patients going in and through or everything, like we have new public management in my country and in several others, that they look at healthcare, it's the same as a Toyota factory. So they look at how to make everything more effective and so on, instead of having an open culture where it's open to discuss problems and things, that we trust each other, and that they trust that we are doing the best we can for our patients. This affects the way we treat patients, because if our main aim is to get the patients through the treatment track as soon as possible, fast as possible, it will affect the way we talk to them. And then we must encourage at all times the patient's involvement, feedback, and having said so. And what's happened in Staffordshire, you have heard about that scandal in the UK, where the report was in 2013. The patients were just treated so badly and many unnecessary deaths. And he said that involvement means having the patient voice heard at every level of the service, even when that voice is a whisper. So make sure, invest in getting the patient's perspective. Also, the patients sometimes, as I said in the beginning, they know much more about themselves and other things that we don't do. And we are so used to being in our system that we see everything from our own perspective. And that means that we do not know how it is for a patient. We can say one thing and the patient can hear another thing, and we can have a reason for doing that. We can think it's perfectly normal to talk in a phone when the patient is sitting next to us. But the patient has a completely different view and we just don't know it. That's why we have to encourage, like they do here at MedStar Health and others. Give us feedback, positive, negative, anything. Then we learn more how it is to be a patient. Then when there has been a mishap, it's this open disclosure is very important. That is something that we often do not do as well as we could. We try to cover up. That's a talk of itself, so I'm not going to give it now. But I think the principle of this Australian open disclosure framework is good to listen. Think about a time when things went really, really bad with a patient. And imagine that this happened to you, to your wife, your husband, or someone you're closest. Imagine what kind of talk would you like to have with the healthcare personnel and the hospital afterwards. If that is our guideline, we will do much better. Very good, guideline for us. The patients are smaller than us. They depend on us being kind and listening to them. So the factors that prevent the patients from feeding back is that if you voice concern, it will negatively impact care. And I'm not sure about you, but I'm sure that some of you have been patients, you have had relatives who have been patients, and you see that something is wrong with their care. But you are a little concerned of talking to the healthcare personnel about that because you are worried they will be upset with you. And that might not be good for your wife, your mother, your father, whatever. So it's a difficult thing. And then we don't want our providers to be blamed if something has gone very wrong. And we are not so interested in that. We want to get well as soon as possible. Focus on the future. And the big thing, they don't know where to report it. So that's up to us to encourage ways how to report. Some places they have the feedback boxes. Sometimes they have online or mobile phone questionnaires and so on. Or they think it doesn't matter whatever I do. But we know, for instance, that if we encourage patients to tell doctors that, well, you didn't wash your hands, it helps adherence to the guidelines. So it's a good thing. Research, just a few words on that towards the end, because we set research priorities, but they are very often based on our own thoughts, what we would like to know. But the patient might have other things that they want to, that are important for them. And there are certain initiatives being set up that it may put all stakeholders together when you are prioritizing new areas of research. And I think this is very interesting for us when we do patient safety research, that we do that together with patients, relatives, all stakeholders. And that's something which is also a principle of this patient safety movement. I'm on the board of directors there. And what really is such a good thing about that movement, you can look at it online, is that it brings together all stakeholders, patients, relatives, healthcare personnel, industry, politicians, hospital owners, everybody together to improve patient safety. And they have this patient safety solution, which is also called person and family engagement. You can look at it and join the movement. It's a global, worldwide movement. And as mentioned in the beginning, this talk is based on the article in the European Journal of June last year. I have talked very fast, covered a lot of topics now, but go deeper into all aspects of patient safety after 10 years of the Helsinki Declaration and start working on it. It's really rewarding work to do. So by that, I would say thank you very much for taking time to listen to me on a Saturday. And yeah, thank you. I'm so glad that you invited me.
Okay, Dr. Jannicke, thank you very much for your very detailed presentations, tips and lessons to involve the patients. I would like to inform you that actually the concept of patient for patient safety or the culture patient for patient safety, engagement of patients, at least in Indonesia, actually has been declared in 2007 by the Hospital Association. But we are afraid of implementing that because we are afraid to be sued by the patient if we speak truthfully to the patients. And yeah, so we have to tell our colleagues how to overcome the fear.
Yes, but if I may just say something to that, but maybe we'll discuss more afterwards. But it shows that if you are open and talk to them, that's sometimes a preventive measure for being sued.
Yeah, yeah.
But
certainly,
yeah,
yes. Okay. The next, for the participant, if you have questions, please write in the QA, and Dr. Jannicke will certainly answer in the QA, and also later after the second speaker. The second speaker would be Dr. Meena. Is a Senior Advisor, Global Action, International Society of Geriatric Oncology in Switzerland, and the Director, Emergency and Surgical Care Program in Geneva, the Foundation for Medical Education and Research, Geneva, Switzerland. Actually, Dr. Meena, I'm the one who invite you to the Indoanesthesia because you are concerned in global surgery, but I do not know you, so I asked Dr. Susilo, please invite Dr. Meena in Anesthesia because we need your advice for the global surgery. So Dr. Meena, topics would be how to create an environment of patient safety and anesthesia service. Please, Dr. Meena.
So, good morning from Switzerland, but I know it is good evening for you. Can you see my screen?
Not yet, Meena.
Yes, you can?
No, not yet. Can you please?
Yes, I have done view, and I've said speaker view and share the screen.
Yes, share screen.
Yes, I am. I'm so sorry. I don't know why it's not.
It's all right.
It says more, and it says we did the that day. I'm not able to understand why it's not. So I'm on the speaker view.
Can you find the share screen button? It should be the green one.
Yes, now I can. Okay. Now can you see?
Not yet.
You have to click the share screen and then choose your slides.
Exactly, that's what I did.
And then click share.
And then you have to click share.
Yes, I have done that because we have shared.
Yeah, okay.
Finally.
Okay.
Yeah.
Yes, sorry. And can you see the slides now?
Not yet.
Not yet, but we will see them.
Okay. Now?
Yeah.
Okay.
Okay. So I will just put it on the big screen.
Yeah.
Can you see now?
Yes, we can see it now. Clear.
Thank you. Thank you very much. It's a cloudy morning here in Switzerland, and I'm sure you have a very beautiful sunny evening, and good evening to all. Thank you very much for this privilege of inviting me to this very important Indo-Anesthesia conference. And most importantly, the area that I'm very interested is that creating the environment for patient safety in anesthesia services. So at the outset, I would like to say that I've been a professor of anesthesiology for a long time, and 22 years. But then I moved on to World Health Organization and went into global public health. So my perspective on this talk will be purely on bringing anesthesia and patient safety into the global public health domain. I've divided my talk into three parts. First, I will give you the global situation of patient safety and then extend it to the challenging current environment of the COVID. And second, we will talk on the education and training tools that already exist. And lastly, how do we implement and go forward in creating this patient safety culture? So, as you know, patient safety is absolutely fundamental to delivering quality essential health services. So, a person traveling by plane has a chance of being harmed only 1 in a million. But during the healthcare settings, the chance of being harmed is 1 in 300 people. Now, we know millions of people are dying or injured annually because of unsafe and poor quality healthcare. Poor quality healthcare, even that leads to a huge factor on patient safety. And although adverse events is now from not only anesthesia but overall, it is the 10th leading cause, amongst the 10th leading cause in death and disability. And 4 in 10 patients during the primary and outpatient health care are harmed. But the good news is that 80% of the harm is preventable. So we know unsafe surgical care procedures, they can cause up to 25% of patient complications. So it is estimated that 7 million per year surgical patients have significant complications. Of these, unfortunately, 1 million of them die during or immediately after surgery. And I'm talking, all these figures are from the World Health Organization, where I had my tenure and I led the program on emergency surgical care. Now, of course, I retired from there. And death, even though has reduced from complication of surgery in the last 50 years, but have decreased, but it is mainly because of the improved patient safety measures. But unfortunately, in the low and middle income countries, it is still very high, 2 to 3 times more than the high income countries. I'm sure you all are all aware that medication errors are one of the leading cause amongst the factors, and I'll be talking about several factors which contribute to patient safety. This is global situation. Unsafe injections not only harms the patients, but also us as healthcare workers. And anesthesiologists are responsible in the perioperative period for blood transfusions. And therefore, if not properly given, they can have reactions and infections, and we are harming the patient. The other factors are healthcare associated infections. Almost 10 patients in 100 inpatients are harmed in low and middle income countries. And sepsis, venous thromboembolism, and radiation errors, overexposure, wrong patient, wrong site, and diagnostic errors are also contributing factors. Now let's talk about the three main things. That's the infrastructure, the equipment, and the health workforce. So here you can see, this was the study that we did when I was in WHO, 22 low middle income countries, and see the gaps in just the basic infrastructure. And amongst that, oxygen. You see it is even less than 50% availability all the time we are talking. Let's look at the equipment. Just the anesthesia equipment and pulse oximeter is just about 50% functioning equipment available all the time. This was one of the largest study that we did during my WHO days. And here you can see the shortage of the workforce. Specifically, we looked only for the first time the surgeons, anesthesiologists, and obstetricians. Obviously, being an anesthesiologist and being in WHO, I was really interested to see how many anesthesiologists and surgeons and key people are there. And here you can see the gaps. You can also see that the low middle income countries, although represent 48% of the global population, have only 20% of this workforce. And we all know in many low and middle income countries, it is really the non-physicians who are providing surgery and anesthesia. And this was another interesting paper that we wrote in looking at 35 low and middle income countries. And you can see the levels of various levels of healthcare facilities. And it is the same thing that it is the nurses, the clinical medical officers who are not nurses and they are not doctors. They are providing anesthesia. Then the World Federation Society of Anesthesia did in another paper, and they found the gaps you can see in red, that they looked at the physician anesthesia providers per 100,000 population. And these gaps is really, really bad because we're looking at huge number of countries where less than one physician anesthesia provider is present. Now coming to the global situation, but looking at the environment currently that we are all, the fact that last year I was in Indonesia in your Indo-Anesthesia conference and really met all of you and made such good friends, and it was so nice. And thank you again for making this forum happen, today with this technology. The stress in a working and the risk of errors that can happen, and I'm sure you are very well versed with it because you have coped with it in a different environment when your anesthesiology discipline was expanded beyond the operating room into the COVID areas of care. And that was the task sharing. You have working with different professional skills, with varied skills, different standards and protocols and checklists, because we are used to even starting of the day with the equipment, anesthesia machine, you have a checklist, you do it like a routine. And there you are in a different environment and maybe you have had stress and there could have been errors. Then the PPE policies could have been different, working in a different environment, and also the infection control. The most important thing was the communication skills. Everybody had different communication skills, and working in a team is not an easy thing, which you would have realized, completely different from the OR settings. Working with different specialists, different doctors, different nurses, technicians, and the whole team was very different. Coming to the equipment, I'm sure you came across the ventilators looking different, functioning differently, a little differently, and that itself, the infusion pumps, the pulse oximeter, of course, are the same. But all these things in a different environment does cause stress, and there are chances of errors. Coming to medicines, I think this was the big, and you may have more experiences. And I just quote you two such news that came with the Anesthesia Patient Safety Foundation in January, where the atrachurium box, although labeled okay, but the phenylephrine inside was, the atrachurium was labeled as phenylephrine. And fortunately, it was alerted much earlier and nobody was harmed. The other case that you would have also heard, which came from Healthcare Safety Investigation Branch, which works with the NHS in UK. And here there was a residual drug in the intravenous cannula and extension line, and the drug was succinylcholine. And this was in March 2020, this year. And you can imagine the implications. So fortunately, again, there was one patient affected, and the doctor immediately resuscitated and ventilated the patient. So that was giving you a glimpse of what could have happened, and you have more experience in that. But I would like to really emphasize that, and Jannicke, my good friend, has spoken so much on the patient's perspective, and I want to bring this to another arena, that how as anesthesiologists we also should be, or with many of the events that has happened in the recent few years, we are very much part of the global public health. And just to remind you that Sustainable Development Goal 3 is about ensuring healthy lives and promoting health and well-being for all at all ages. And therefore, safety of the patient is a prerequisite for strengthening healthcare systems and the UHC and Sustainable Development Goals. This is what the World Health Organization has mentioned and recognized. The other big factor which happened in 2015 was a complete, I would say, a historic turn for us anesthesiologists and surgery. For the first time, a historic resolution during my tenure had passed and approved by 194 countries, member states, including Indonesia, was on strengthening emergency and essential surgical care anesthesia as a component of universal health coverage. All the professional bodies, including WFSA, and all the governments were involved in this. And really, this was the biggest news for all of us. Now, lately in 2019, and you may not be aware, but there has been a global action on patient safety resolution passed again. And it really talks about recognizing patient safety as a health priority in all health sector policies, programs, etc. And also recognizing that it is a very essential component of strengthening healthcare systems in order to achieve the universal health coverage. Not to forget that we need to, it calls on the governments and health leaders and authorities to integrate and implement these strategies into all clinical programs. And here you can see even surgical program is included, highlighted amongst the others. So how do we go forward? Do we reinvent the wheel and start with some patient safety education tools? I don't think so. We can start right now. Yes, we can develop some more. But just some tools that I would like to highlight here is one that I worked during my WHO days is this. This is absolutely the basic essential emergency equipment. So basic that I don't think you can take out any out from this. And it can be at any health facility level, in the wards, anywhere. And this is absolutely the basic. WFSA, then WHO also developed, all of you are aware of this, and I will not go into details, of the surgical safety checklist. It just highlights very clearly, we are all used to all the checklists that we start our day, I mean, as anesthesiologists. But this really highlights before induction and during the procedure, before incision, and before the patient leaves the OR. And here I would just want to highlight about the marking and identifying the patient, marking the correct site, etc. And this should be highlighted even more in more of the countries. And as I see in more of the high-income countries, it's almost become a routine to mark the site of the procedure. World Federation Society of Anesthesiology recently also came up with international standards for a safe practice of anesthesia. And this is so welcoming because it talks about the absolute essential anesthesia kit. That is absolutely essential if you are going to be considering emphasizing on patient safety. And they're talking about pulse oximeter, capnographs, and airway management equipment. My good friend Jannicke has given such a beautiful talk on engaging the patients. And this is really my emphasis and my favorite right now, because having worked as anesthesiologist for 22 years, having worked in the global public health in 16 years in WHO, created all those resolutions and all those. But this was really close to my heart because I felt we have to engage the patient. So therefore, with the patient safety group, we created this one-page flyer, and it talks about very clearly empowering the patient to take care of their own safety. Because patients are rightly so, as has been pointed out, are very scared. They are talking more to the surgeons and to the other people. We see them just the night before or for one day before. And what are the questions that are going in their minds? And here you can see they talk about, what are the food and the fluids, telling about the medical history, their health conditions, their anxiety, what they are worried about anesthesia, the pain, especially they don't know anesthesia, many in the low and middle income countries, but they are afraid of pain, and they might say, and then that's a chance for them to talk to you with these leading questions. And then after surgery, what are the leading questions? What they can do, the activities, what are the medications, when do they come back? I will not go into that, but it's just one page. And this is a flyer that can be shared readily by everybody. In all people are in the waiting rooms and TV, watching TV, immunization, etc. Why they cannot also read this amongst all the other magazines and newspapers, I'm sure, and this will empower them. World Health Organization, now coming with the patient safety, very much emphasis on that, has come up with a generic tool. Here they're talking about speak up about patient safety for your own safety. And they are very clear things. One is talk about your own care to your provider. Be informed, ask questions, don't be afraid. And then give full information about your medical history. Do not be afraid. And you'll be surprised to see that it has huge implications on financial savings and better patient outcomes. Almost to 15% you can prevent the harm. So that's a big number if you look at the population that you are serving. Recently also WHO, we know that we cannot talk about patient safety in isolation. Health worker safety is of prime importance, and you better than me, you have seen it in this pandemic situation. You've seen the reports, you've seen the news, you have been affected. And here they came up with, this is called the WHO's Health Worker Safety Charter. And I put it up here with all the links. There are 5 actions they've asked. This is to call upon health authorities, to call upon the governments to protect health workers from violence. These are actions. Improve the mental health of the health workers, take care of them. Protect them from physical and biological hazards. Advance patient safety in the national programs along with the health worker safety. You cannot be putting, I know patient safety policies have been formed with all this global action, but we have to voice our opinion as health workers to involve that without us, without the patient health workers, we cannot have the patient, we cannot be saving the patient. You'll be very interested to know, and I was also giving my comments on this, is the global action plan, which is being developed, is the WHO's third draft, which was in 2021, this year. And they're talking about patients. This will be a strategic direction for all policy actions, implementations at the point of care and recommendations. So here we can then, so we just, we have heard such, it's good to be the last speaker, I say always, because the words, the pearls of wisdom has already been shared, and I am just taking those little pearls and emphasizing them. And here, I again would like to, my favorite is this, that without patient engagement, awareness in their own safety, I don't think we can move much. We'll be talking to the same people and same all the time. So we should be telling the patient questions on anesthesia techniques and safety, pain relief, allow the patient to share their experience, not afraid. Maybe we can, when we go, I know surgeons go for the post-op round, but we can also find out, we know the anxious patients because we were with them, we were vigilant, and ask them anything, how they fared with their anesthesia, how was it? And what has been lacking, and I've been saying to everybody, and this in high-income countries has gone way, way forward, is about advocacy about anesthesia services. We blame ourselves, and we keep saying nobody knows us, nobody, and I'm talking from the perspective of low and middle income countries, seriously, that we complain and complain. The people know surgeons, and we have jokes about them, that how they know the surgeon, and poor anesthesiologists. They don't even know sometimes, they're even doctors. They sometimes know, yeah, surgeon took care of all our problems. And I can go on and on about the jokes that I've experienced, etc. But if we don't talk and we don't propose what we are and what we do, then why are we complaining? Why are we complaining? And very quickly, this was on the World Patient Safety, on the World Anesthesia Day last year, that I helped, coming from India and being part of the Indian Society of Anesthesiologists as well. I was instrumental in working with the Indian Society of Anesthesiology to create this one-page flyer, which was launched last year. And this year, and since then, it is being circulated and given to all the anesthesiologists to print it out. It's just one paper, one front and back. We purposely kept it that much. And this is just a glimpse of it. It's got about 6 questions, 7 questions. That's about all. And it talks about know your anesthesiologist. And then you reverse the page, it says know about your anesthesia. And currently, of course, this is something that if Indonesia is interested, and I'm happy to work with World Federation of Society of Anesthesia, how we can bring these, adapt what already WHO has the tools and WFSA has adapted to the country. And this is being currently also, I'm told, in India, translated into various languages because we have 22 official languages. Now, nothing can be more proof that we are all sitting for 3,000 people, I was told, who have registered for this conference. And great congratulations, Dr. Susilo, for your leadership. And here, so we can utilize technologies. And why not? We heard about Norway, having a absolutely workshop or training or whatever it is that it's mandatory. Why can't we also do the same? We can have for this continuing professional development. And this is something, again, is huge interest for me. How can we have these little little, just maybe 30 minutes workshop, 1 hour workshop, where people, our team, anesthesiologists, can have the clarity of the roles and responsibilities. And I saw one of the comments, and I have to say they were that we see them last, and the surgeon has already talked with them, and there are surprises for us. So let's have this clarity of the roles and responsibilities. Let's talk in this utilizing technologies. What are we supposed to collect information? Adverse events, near misses, what are these? And how do we communicate scientific evidence to the patients, to everybody? We are very good as clinicians. Of course, I'm sure and I was watching the Indo-Anesthesia conference. Everybody's an expert and they talk so much about the expertise. How about communicating the scientific evidence into very simple languages for the rest of the people? Clarifying now with this infodemic, WHO has said it is surplus of information, good or bad, which can harm the people. And this has happened in the pandemic, and it always occurs during epidemics and pandemics. So how do we clarify misinformation, disseminate the correct information? This is very important. And we all are part and parcel. We can't say, oh, this is meant for people who are dealing with only infectious disease, etc. Only COVID. No, we are all part and parcel of this. Pandemic has taught us to be together as team, within a team. So we cannot just go ahead and say that, okay, we can ignore ourselves. No, we have to be in the forefront, I feel. And lastly, leadership. Because why? All the financial investment, if we cannot convince our leaders, however small, it could be at the small district hospital, the leadership has to be involved. Telling them about reducing risks, errors, harms, healthcare's workers' well-being. Positive recognition should be given. Avoiding this thing, the shame and blame attitude that many of us, we don't even have in many of the low and middle income countries. We don't even have a multidisciplinary task force with a positive approach. It is always, oh, this happened in anesthesia to so-and-so anesthesiologist, or this happened by so-and-so the nurse, or it happened by the surgeon or so-and-so. So we need to brush up that and bring it to the leadership. Making sure, these standard protocols, all these have to be also implemented as policies and plans. We have to start step by step, start small, but the leadership, having the blessing of the leadership, I feel is very important. Reporting system, what are we supposed to report? Is it burdening our day-to-day anesthesia services? Can it be made easy? What are we doing with the data analysis? Is it blame and shame? Or are we going to learn the lesson from these errors, improve our strategies, and keep continuously changing, sharing without the names? So that is the key that we need to work. I would like to conclude that being part, now my entire work is on medical education and creating short courses, etc., online, etc. And knowledge sharing is the power we have. Training, mentorship, and to be part of the policies. Please do not, as anesthesiologists, sit at the back and then we complain and say we were never called. Why is the obstetricians? Why are the pediatricians? Why is everybody else on the table and the policies? And we are not. So we need to be there if we want to make a change in patient safety culture. Terima kasih to everyone. And I remember this lighthouse last year in the Lombok area. Hope to visit you again. And you should be the lighthouse as anesthesiologists. Thank you.
Thank you, Dr. Meena Cherian, for your very, very interesting updating us for the patient safety and anesthesia services. And now come to the Q&A answers, Q&A sessions. First, I would like to ask Dr. Jannicke, you have questions as anesthesiologists, most of the times we are in the last person to see the patients. Any opinion on this? Especially sometimes major decision has been made without us. Please, Dr. Jannicke.
Thank you. First, before I answer that, I will just give a comment to what you asked before, and that it was about litigation. And that's from a previous talk, the reasons for why people sued doctors. And as you can see on the top here is that it should never happen again. I wanted an explanation. I wanted the doctors to realize what they had done. So very often it is because the patients and relatives do not understand or have not been receiving any information. And that's why they try to desperately get to know what has happened, showing that it's not money and to punish us, which is the main reason. And while I'm sharing the screen, I will also just give because I've seen some of the answers and another question, so I'll just show you one more slide and then I will come back to the question. And this is about PPE, how you can improve contact or communication, even if you are heavily dressed in PPEs and so on. Putting our name somewhere, it's so that we at least have a name tag on all the people in the room and so on. Simple things like that help. And this very special PPE you can see to the right has been made for children. So I just wanted to show that, and then I'm stopping sharing and I'm coming back to your question. And that is, it's true, it's difficult when we are the last patient and suddenly are just given a case to anesthetize and that's it. But yet we can help to make the patient comfortable in the situation. I have had some instances when I have seen the patient reacting and have not really understood what's going to happen, when I have stopped anesthesia, the procedure, and said, I'm not doing anything more until you have spoken to the surgeon again, for instance. One special case, because we do abortions in this country, and not all, it's difficult patients. And there was one patient who was in for an abortion, and she was just crying and crying and crying. And I said, oh, you're so sad, is this so bad for you? And she said, yes, because she had just had 3 children, she was a dentist, and she felt she couldn't have the 4th children because she would let her patients down as a dentist. And I said, if that's the case, I think you have to discuss more with the surgeon before you go through this thing. And we put her back to the ward. Unfortunately, she had already got some pills to prepare everything. But at least, even though we are the last person, we can make the patients feel comfortable and listen to them in that situation. It's a big topic, but that's just a comment. Thank you.
Thank you, Dr. Jannicke. Yes, and the other questions is, do you have any tips for end of life in palliative surgery? If something happens during surgery, resuscitate or DNR?
What was the tips for? Could you please repeat?
For the end of life or palliative surgery.
Yeah, that's again is a very difficult question. I think we should let patients and relatives know before we do that there are risks involved and so on, so that at least they know, but that sometimes the alternative is also not good, but ensure that they understand that there are risks involved. And if something happens on the table, of course, we have to tell the truth and talk to people, the relatives and so on. And again, there are some causes. There is one case which is in the Patient Safety Movement website in the US. There was a boy, 8 years old, died during surgery, and the relatives never got to know what had happened. And they never came to terms what happened. They tried to get an explanation, but again, the hospital was afraid of getting sued and so on, and they were just meeting with a wall. Then after 10 years, the mother got a letter from a physician who had been in the room, and he said he had been struggling with this case for 10 years. It took me 10 years to write this letter, but the thing was that your son was mistakenly given some kind of medicine that made his blood pressure just go over the top, and that's the reason why he died. And how somehow the relatives got to understand that, okay, that was the case. There's many other examples, even in my own country, where we are so-called so open and so on. A patient in the emergency room who was intubated he was a colleague for suicide. He was intubated in the esophagus. They decided not to tell everybody. And after 3 years, the son understood, the family got to know that something had happened in that room. And then the son had thought for 3 years that he was the cause of his father's death because he had dialed the wrong number to 911. So these are just a few examples to a big topic. I'm not sure whether that was an answer to the question, but there were some more reflections at least.
Yeah, thank you. Yes, it depends on the situations, it depends on the culture, and also
Very much so.
very.
But I think sometimes we might use culture as an excuse.
Yeah.
So the cultural things might not be as bad as we think they are, but they are convenient for us. Because we have used the same explanation here.
Yeah, and maybe empathy also have
Absolutely. Absolutely. Show you care.
Yeah. Okay, the other questions about PPE, and I think you already answered. The other question is how to increase awareness about patient safety issues to the hospital management level.
Yeah, thank you. I think Meena gave a very good talk on that also. And I'm pleased to say that during the G20 meeting last year, patient safety was also made as a priority among the G20 people. So I think it's on a state level, governmental level, it's a commonly agreed thing that this has to get priority, and it's good investment. For every dollar or whatever currency you might have, you put into patient safety measure, you get tenfold back. So it's important that the politicians understand that, and that this is nothing that costs them money, they will earn money and so on. But I mean, this is a long-term work. So I understand it's difficult because it takes some time before it goes down from the G20 countries, the WHO. What they agree in Geneva might not be so easy when it comes to everyday things and so on. So, but it has to come from the politicians and the governmental level priorities.
Yeah, certainly. And I think that the hospital associations and the regulators has already have a plan for the hospital accreditations, which already included the patient safety issues in their accreditations.
Getting there.
Okay, and the other question is from Akhir Nur.
Meena want to also share.
Okay, please, Meena.
Yes, you were. I just wanted to add on that often we think that as clinicians or as professional societies that is enough, but you really require at a large scale, and really if you want to mandate and implement inside the policies and plans of the country, and you really want to go robust on something, it has to be the politicians, the political factors have to come in. And I've learned it a very hard way, because I was a complete anesthesiologist who had never stepped out of the OR for 22 years. I was giving cardiac anesthesia, basically, just so that you know. And it was a surprise for me to come here in World Health Organization in 2000 and to find that there was nobody. Even I know that all the professional societies were doing such good work, the surgical, the anesthesia, everything, but It was not placed in the public health forum, just like with other things. So it took me 4-5 years for that. And then ultimately to get the program took me 2 years. So 2004 only it was blessed for the first time, not diluted. It was surgery, surgical care, which included anesthesia. So I felt the power. Then I understood why. And then when the resolution came, I understood even more that it is so important. And really I learned public health through experiences in WHO. Otherwise, I wouldn't have known. I was a complete clinician who had no clue, because I don't deal with immunization. I don't have anything to do with, mother care and things, like exactly for the policies. So I feel that as anesthesiologists, if I learned it so late in my life, I think now younger anesthesiologists and everybody should be on board right in the beginning. Thank you.
Yeah. That's why we are very grateful for your doing what you do in WHO. Usually anesthesiologists is only in the OR. they don't think it. But we need that regulation. We need that we have representatives in the regulatory, in the health department, also in the world, as if in the World Health Organizations. And we are very grateful that we have somebody like you in there. Okay, thank you.
Thank you, Dr. Bamman, for your kind words, but I was. No, I'm not.
Yeah, no, it's not was, but you are still advocating us.
Thank you.
Yeah, the other question is, in Indonesia, many rural areas do not have anesthesiologists, surgeons and nurses. Surgeons and nurses must act as anesthesiologists. What is your opinion? What can we fill in the gap for Dr. Meena? It's for you, Dr. Meena.
Sorry, I'm just trying to that in palliative surgery. No, I didn't see the question. Sorry.
In Indonesia, many rural areas do not have anesthesiologists, so the surgeon and nurses must act as anesthesiologists. They do anesthesia. What is your opinion? How can we fill in the gap? As you know, that Indonesia have many islands with few inhabitants, but we have also hospitals there, but we have no anesthesiologists there. How do we do surgery there and no anesthesia people do? How is your opinion? How we do fill the gap?
I think it's a wonderful, excellent question. And just as a background, that I have been to your very remote areas like Ambon Islands and all that, as in the missions, after my WHO days as an anesthesiologist. So I know what you're where this question is coming from. Now, my thing is that we have shown the shortage of specialists. And then WFSA has also shown the shortage of physician anesthesia provider. So there are some doctors who are not anesthesiologists, but they are giving anesthesia. Now we are coming to another area, which is the nurses you're talking about. Now, this is something I've always said, and I was asked this, is that we need to draw upon, you have the global situation, you have these evidence, and then you have to build on the evidence within the country and create this as it's a problem. And when you have a problem, there has to be a solution in the country by the people in the country. So there is no point saying, oh, well, in Africa, the nurses give anesthesia. I was told so many times, yes, I know, I've worked in Africa. And but then in India, for example, then you take India, there's no nurse anesthetist. Then you take UK, there's, and then US, there is. So every country, one size does not fit all. Every country needs to have a trained professional. Now, training can be either to the nurses or there is a proper training, not just hands-on, which has been happening. And that's why then you have errors, then you have harm, then everybody's blaming everybody. And then you go to the political level, at the national level. And I know it, that look, and it comes in the newspaper that this person was not authorized and was doing the work. And it's my experience. 40 years ago, I was operating, believe me, I was not an anesthesiologist, but I was operating only on obstetrics. I was to do all independent cesarean sections, hysterectomies, etc., independent in a very rural hospital. But that was the time needed, and it was 40 years ago. Okay, so I'm not justifying, but then it was required. And being a female in India, I had to do all that. But now the time is, we are all very much advanced. You have societies, and therefore this needs to be addressed with evidence, not that there is just a shortage, somebody said, no. And then you're empowered to have a proper training program. And I believe it has to be a proper training program, which is authorized. I know that a lot of people come, go, do 2 months or 3 months training, and then there is an opposition. And believe me, I've seen that also before this resolution. I was seeing a lot of that in many countries, for specifically, and I'm talking also of hernias and small surgeries. People would come, give them the training, and then they couldn't operate, because then the few surgeons, 5 surgeons in the entire country or 10 were opposing, or that 1 anesthesia or 2 anesthesiologists opposing. So let's take this as a big picture where the government has to be on your side, and you have to be powerful. And I would only advise that. And it is not a black and white. It needs to be having some agreement.
If I may add something, I think it's important that you as anesthesiologists, that you take the lead. And if it's like this, that there are not enough trained anesthesiologists and others have to do it, yet you can be in charge of their training and so on. And that's what the Americans said, have said earlier, that when they started, the nurses there, the doctor said, no, we don't want to do anything about it. If they at that time had taken the leaders, so they were the natural leaders in the country of all anesthesia services, even though it was not perfect, then you still will be in charge, and you will be powerful in that education. Otherwise, you might risk sidestepping in a way. But it's true what Meena says, one size does not fit all. And your situation is as it is. I mean, they won't disappear tomorrow if you say you don't like them. You won't have solved the problem. What do you think?
Yeah, thank you. In my opinion, yes, task sharing or task shifting is very specific for the area, for the region. It's not the same in Africa, in Asia, in America. Also in Indonesia, they have a specific problem. They have a specific geography. So we have to solve it specific for Indonesia. And I agree with Meena and you, Jannicke, that we should issue it to the authority, to the government. And the point of view is not for us, not for the doctors or the nurse or the society, but the point of view is the point of view of the patients. How do they get anesthesia service properly? And yeah, we should help the authority how to regulate the anesthesia service. Yes. Is it that? Yes, Meena, please.
To elaborate on that, I just want to share one country experience where the country themselves have created, it's called technico-chirurgy, and it's in Mozambique, and I've been there, and I've seen them operate. So they are given a few, these are technicians. Technicians means they're not nurses, but they're given a proper training for 4 years, 3 years or something like 4 years, and only specific essential surgeries to be performed. And they do not come in the main urban cities. They are working in these remote, and they are under the umbrella of the Surgical Association. So it is with the government, with the professional society, and being trained by them. So it is not an isolation. And when I was talking, I took a workshop for them, and they were saying it is, surgeons were taking the workshop, and they said this is wonderful because we are not planning to go in these remote areas. So this is a very good example, and it has thrived in Mozambique, and it was started long, long ago, many years ago. Thank you.
Thank you. That's a very interesting solution. Okay, we go to the other questions. During the pandemic, many of us have to change our role. Even non-anesthesiologists must be able to handle COVID cases. How to ensure we deliver the same quality of care for all patients? Dr. Jannicke, maybe you will answer it.
Yeah, well, that's of course very difficult to ensure because we have different levels of competence. What we have done is that we have started again to provide, to train shortly other physicians and so on to do the ICU, to help us in ICU and so on, but that we are available for questions and support. Of course, that's not so easy to do real time always, but at least that we try to have some, it could be also online training and so on, and that they are working in teams and preferably with us. But again, we have to take the lead and be the leaders in that, if that was an answer.
Yeah, teamwork, yes. Dr. Meena, you have...
I elaborated actually in my talk. I didn't have much time, so I didn't elaborate. And this is something that pandemic, okay, pandemic is bad in every which way, but we have also have to look at what are the positive things that we have achieved. One is the technology, and this could be a continuous professional development right now, as of today, as of yesterday, that you could share the training through the technologies to the teams, the people who are non-anesthesiologists who are coming in to help, because this is not, this is actually a wake-up call that how we can work as a team and how we should be prepared. It's almost like an emergency when you have you're preparing yourselves. So this is something that tools can be utilized, made, and training can be done. So it's really about education training, and you can do it with using the technologies right now.
Yeah, thank you. Yes, maybe so it's teamwork and also collaborations between specialists.
Yes.
Okay. The other question is, in such a densely populated country where there are many perioperative tasks to accomplish, how to adapt WHO patient safety and gain engagement, especially during pandemic and low-tech patients. What's low-tech patients? Dr. Jannicke, maybe?
I couldn't really get, could you please repeat?
Yes, in such a densely populated country where there are many perioperative tasks to accomplish, how to adapt WHO patient safety and gain engagement, especially during pandemic and low technical patients.
Yeah, no, I think what's good with the WHO guidelines and so on is that they are often appropriate for high, middle, and low income countries. So you just have to see what is feasible, but the principle is safety and communication with the resources that you have. But this was probably not what, I'm not sure if I understood the question properly. Maybe Meena understood it better than me.
I don't know either the questions. We move to the other questions. Yes, Dr. Meena, please.
I think if I understood, this is like everybody's, again, communication, so I'm understanding in a different way from my friend Jannicke, is this that maybe the person means that I was showing all those education training tools, and I was showing WHO patient empowerment tool. So what I did is I also gave you an example on a very recent one, how they are adapting it. They have adapted actually to the patient empowerment for their own safety. So this is something WHO does not, if you look at any of the standards, all those tools that I was showing, and even WFSA, you see, is really the minimum things that you must have. So when I was there and I made this patient communication information tool, if you look that green one that I was showing, it was really the basics. Now you can add hundreds or more questions on patient safety in that is up to you. But this was really the basic. The same when we adapted for India by the Indian Society of Anesthesiologists at the highest level. Again, it was only 7 or 6 questions on either side. Absolutely the basic, that these must be asked. Why they must be asked? Because they really the basics for empowering the patient to say that, yes, I asked these questions and how I can feel safe. So the person maybe means that in this pandemic, when they're so high, can they go higher? No, they can still have quality by putting these minimum standards at least, which is lacking. I just showed about the oxygen, anesthesia machine, etc. Stock out, stock in, how much actually functioning equipment is there. I mean, do we know? Do we even know that the resuscitation bag, actually the bag inflates? And, we've seen so many things. Do we know oxygen is available continuously? I mean, what is the meaning of oxygen sometimes available? It has no meaning. So minimum things can be then go step by step and create minimum things is creating quality. Quality does not mean going to the highest level and having a helicopter on the hospital roof to be taking the patient off to another place. No, it means you could resuscitate there. Yes, I believe in that. Having worked so long.
Excuse me, but just one more. You also have the patient safety checklist. I mean, the WHO patient safety checklist. I'm not sure some of that can be done, so at least you know what kind of standards you have in that specific situation or what you have available. Another thing is that when you do the checklist, at least everybody in the team speaks up. And it has been shown that just saying your name makes it easier during the procedure, later in the procedure, to raise your concern if something is wrong. Simple psychological things.
Yeah, the same language. The same language and the basic standards. Yeah. Okay, thank you. We have interesting questions from Dr. Chan Yueng, our colleagues from Singapore. Disclosure must be encouraged when things go wrong, but this must be matched with a peer support system in the organization to help the doctors or healthcare personnel involved. Organizational culture of shame and blame will not allow open disclosure be adopted. Any comments on how to improve? It's about open disclosure.
Yeah, if I may, again, this is very important. The culture comes from the top, very much even from all the way up to the Ministry of Health. If they encouraging patient safety and so on, then it will be easier on a lower level. Because it really has to be encouraged from the top, I think. Because if you are open and you are silenced by everybody and kicked out and so on, but even though it's important that culture comes from the top, there are things you can do on an individual low level as well, by making friends with your colleagues and trying to be open and discuss things and so on. I had the professor I had when I was trained. I thought he asked so many stupid questions, And I always thought, you should know these things. You are the professor and you don't know that? And then it turned out that he asked all these stupid questions just so that we should feel confident asking stupid questions. So by asking those questions, he encouraged us doing the same things. So there are many things we can do in our small environment, but to really have it through the whole system, it has to come from the top as well.
Yeah. Dr. Meena, do you have opinion on that, the open disclosure?
I think it's an extremely good proposition, but have we reached that level as yet in low and middle income countries? And we should be, I'm saying, but have we? And my comment is, can we still start small? The things that are so much that we can implement. We just talked about empowering the patient. Then we talked about what are the tools that can be given to the patient. Mm-hmm. And when that comes from the ground, disclosure will automatically, slowly, you will see how countries are moving towards that. Legally, etc. Even now, low middle income countries are having legal problems, and everybody is aware, getting aware. This was not the case long ago. So we are evolving as low and middle income countries, and it's important. Can we take small steps first, which are feasible, rather than starting here? I'm not saying it's not important. Yes, it is very important. Maybe at the same time, maybe Indonesia has advanced so much. But can we start with ourselves now, today? Mm-hmm. What can we do from tomorrow in our OR?
Okay, thank you. And for what that I know that open disclosures has been started by our colleagues in Australia, and from that I know that open disclosure is now one of the standard in the hospital accreditations. So the hospital must encourage the open disclosure if they have adverse event problems in their patients.
I think I allow Dr. Chan.
Chan Yuang, yes.
Yeah, if you want to give some comments, just unmute.
Please, Dr. Chan Yuang.
Yeah.
Hello. Yeah, hello. Nice to see you again.
It is very, very, for us, we are very, very, we have a system in Singapore General, and I'm quite happy to have that. It has to be built it's part of our mentorship program as well, to make sure that junior staff and every staff has someone that they can go to, so that if things don't work out well, there's someone that they can talk to. And we do support them, whoever that's involved. And the hospital actually have a group of legal officers and risk management team to ensure that both the patient's interests, the family interests, and the doctors, the medical team interest is also properly protected. So we have a system, but I'm just putting it out as that you must support your doctors and nurses who are involved in critical events. Because I remember during one of the meetings that I went to, a workshop, that a very senior person from another country says, it's so sad that when something happened, the surgeon was so depressed that he had a stroke a few years later. The anesthetist committed suicide. At the end of the day, the patient, the family got the amount of money from the suit, and all they said was that, is that all that I have? or all they receive. So that was a very sad story, that things don't work out, because most of us are very emotionally involved in patient care, and we can help many people. But if there's only one case that didn't go well, we truly suffer, and not just us, our families and all that. So it can be quite traumatic if we don't have a very good peer support system. Thank you.
Yeah, thank you, Prof. Chan Yueng. Yes, that's what the accreditation tells, the Australian system tells, that we have to have the peer support and also the organizational, the director support in the open disclosures. Well, thank you. And the last question is from Sashi Fora.
I think Dr. Sashi already. Dr. Sashi is coming from the UK.
Yeah.
Sashi, your mic's already open if you want to give a statement.
Hi, good evening where you are. Actually, it's morning here. I've really enjoyed all the lectures I've attended this morning. Thank you all, especially to Sushila for organizing this absolutely slick technical presentation and the music. Yeah, just a little comment that I wanted to make about patient safety is that it's become even harder to maintain communication these days. You've already addressed the PPE and all the barriers. I think and patient to physician communication has been emphasized, and physician to patient communication has been emphasized. But what hasn't been actually been addressed or actually been overlooked is physician to physician communication, which at the best of the times was difficult, but has become even more difficult in the current environment of theater noise, PPE, and we are all kind of maintaining our distances. So the error margin has actually increased. And I think we have to be extra vigilant from now on as to what we are saying and how we are saying, and whether we are audible or not to our ODA or our assistant or the person who's handing us the drugs, because if they don't understand what we are saying, you could be given the wrong stuff in an emergency. And if surgeon asks you to do something and move a leg, or you move the wrong leg for the patient, so that kind of thing can happen. So my point here is physician to physician communication in theater has to be improved. It has to be addressed, and one has to be super vigilant about it, especially when you are in a stressful condition.
Yeah. Please, Dr. Jannicke. Yes.
Yeah, thank you very much for that very valid comment. One thing, this is a difficult topic and cannot easily be solved, but one thing which becomes extra important in such a situation is the double loop communication. So that you always repeat the message to feed back to the person who's giving the message. Can you collect 4 units of blood? Yes, I'm collecting 4 units of blood. And the message has not been received until you have got that feedback. That's just one small example on how you can ensure that at least the listener has understood what you are trying to say. But I think we cannot completely overcome that very big problem.
Dr. Meena, do you have any comments?
No, that was a very nice point which she made. And I did mention, but because of the time factor, if you remember in communications, I mentioned that we have to utilize the technologies to learn many things. And one of them is how to communicate. And that is very important within that continuous professional development. And this is, nothing can be more urgent than in this current situation, that why people cannot be trained and mentored in that. And that's all for patient safety.
Yeah, my point was especially in relation to drugs, because you might say atracurium and somebody might hear it as vecuronium or cisatracurium or whatever. Just a silly example. But I think in anesthesia, where the margin of error is so low and the dangers are so high, that is where the verbal communication, maybe we should have placards or like little like a postcard kind of thing with the names written on it, so that there is absolutely no chance of misunderstanding what's being said. I don't know, just one of the thoughts that's occurred to me just now.
But that's also part of the double control, what we are doing. So I think your suggestion is good.
Thank you.
Okay, thank you. Yeah, I agree with Dr. Meena. We can use other means like WhatsApp, WhatsApp with relatives of the patients in the COVID ward. Yes, they do explanations. They will explain. So we can WhatsApp them and tell the conditions of the patients, and yeah, it's just like that. And
just one mention, but if we talk about WhatsApp, I'm sorry, but I get so eager now. But that's how to communicate with relatives. I did that first time 10 years ago when I was in Norway and ending a patient in ICU. And her daughter was in Singapore. I was in the winter in Norway. And so we did it on Skype. So she could watch her mother die on Skype from a kitchen table in Singapore. And how she fed back to me how important that was for her afterwards, that she was able to take care. So, I mean, that's another type of technology, how we can use it. Just like I now feel I'm on the beach in Indonesia, looking at Kresa, and in the rainforest, looking in Susilo, and in a cultural place, looking at you, Bambam.
yeah.
Okay, probably one last comment from Dr. Chan. Dr. Chan, you?
Okay, I'm YK Chan. We were talking about disclosure or non-disclosure.
Yeah.
And, the thing is, I think full disclosure of a situation that has gone wrong is actually very comforting for all. And sometimes the whole situation or the whole story only comes out in court. And that's when the agony and the stress is actually prolonged. A lot of times we all don't realize. When you go to court, the judges as well as the two sides, the lawyers from the two sides, have a way of making you come out with the truth because they look for the facts of the case. They look at the consistency of what you did, and their experts will guide them as to what really happened. It is actually very, very interesting how it all works out. And to have to go to court, especially if you have been trying to hide your facts, the truth will come out. And when the truth comes out, after being hidden for a long, long time, the stress of hiding it is already very damaging to the body physiologically. And the fact that you have to actually kind of have a public confession to the judge is even more so. And that may actually explain all the strokes that the anesthesiologist had, with regards to Ewing's case. And it is all the stress that is kind of bundled up in a patient in a provider who has done not quite right, but not given an opportunity to tell the truth because of the fear of the damage they have to pay for. Well, just imagine yourself in the patient's shoes. If the patient's life has been damaged, I think as a provider, we owe it to the patient. Most times, we don't really have to pay it from our own pocket. The insurance pays for it. But just imagine you were the patient. You would appreciate being told the truth, being given the alternative to lead a life that could have gone on, but now compensated for by the compensation itself. Put those things into your mind when you fail to disclose the truth. Because the damages that we all talk about, some of them is obvious. A lot of it cannot be visible to us as providers as well. So don't wait until the case goes to court. Might as well make life easy for everybody, including the lawyers. Because it's also not easy to be a lawyer trying to find out the truth that happened in the other side. But their experts will help them. And as experts, those of us who have worked as experts, don't look at the case. We don't cite anybody. We look at the situation. It's not logical. You are supposed to be patriotic to your science of the whole provision of care. Correct? All of us, we've been there. And you realize you can't deviate from that. The judge and the lawyers will have a way of extracting all this information. There is no way you can hide from justice for the patient sometimes.
Yeah, thank you, Dr. Prof. Yo-Chan. Yes, that's the use of open disclosure. So we can tell the patient and the family what's the truth of the case openly, and how to overcome the problems with the patients. Yeah, that's the idea of open disclosure, was it? Well, I think we have answered all the questions. Krisa?
Yes, very well. I think the discussions already well established. A lot of things to be discussed actually. Open disclosure and a lot of the hospital and the political management. I think we will save it for the future conferences.
Thank you for all of you.
So actually, this is a cue for Dr. Eddie and Dr. Susilo to prepare future meeting in the field of patient safety, because I agree this is something that we don't talk enough. Yes. Oh.
I agree.
But it is very, very important, and I think this is a very interesting topic as well for all the health worker, not only the anesthesiologists actually. So I agree. I think Dr. Meena and Dr. Jannicke already said that we as anesthesiologists, we must act and start the thing about patient safety. All right, thank you very much, Dr. Bambang, Dr. Jannicke, Dr. Meena, for your extended presentation, discussions. Thank you for all participants who already give their opinions and insights about patient safety. This is our last session of the day. Tomorrow is our final day of Indo-Anesthesia. We have 3 more sessions. 3 more sessions, 2 more music breaks.
That's what we are waiting.
Waiting for the music breaks.
Yes.
I was up in the morning itself to hear the music, and I wanted to just continue. It was so beautiful.
Thank you very much.
Thank you very much.
See you all. Bye-bye, everybody.
Bye.
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 Thank you.
Thank you.
See you
Bye.
again. Thank you.